Okay, hello everybody. So welcome to Pulmonary Embolism Grand Rounds. It is my absolute pleasure to have everybody here today. A brief introduction to this new series. This is truly a multi-institutional collaborative effort that's coming to you free of any conflicts. So we are my colleagues who lead the Pulmonary Embolism and Pulmonary Vascular Disease program at their respective institutions. We have Dr. Hooks, who is the National Co-Director for the PERT program for Ascension. We have Dr. Sarah Higab, who's the Director for the PERT team and the Associate Director for Pulmonary Hypertension at Henry Ford. We have Dr. Vizawati, who's the Director for Pulmonary Hypertension program at Ohio State. And we have Dr. Sanjum Sethi, who's the Director for the Pulmonary Embolism Response team at Columbia Presbyterian in New York City. And I'm Vikas Agarwal, and I'm a pulmonary interventionalist at University of Michigan. So welcome and thank you for joining us. What happened to my slide? Okay. So our series is called Pulmonary Embolisms Grand Rounds, and it's a monthly how-to CME webinar series in the area of pulmonary thromboembolic disease and pulmonary vascular disease. It's going to occur every month on the third Wednesday from 6 p.m. to 7 p.m. And our goal is essentially to learn from each other. We want to talk about how we all can establish specialized micro programs in this field at our institution, and they are interdisciplinary and collaborative. On that note, our topic for today is how to set up a balloon pulmonary angioplasty program. This is the QR code for the CME credit for the audience. We will show the QR code again at the end of the seminar as well. And it's my distinct pleasure to welcome Dr. Kenneth Rosenfield, who needs no introduction, but he's the section head for vascular medicine and intervention at Mass General Hospital, a true pioneer in the field of interventional cardiology and pulmonary vascular disease. He's the founder for the PERT Consortium and is now leading the Balloon Pulmonary Angioplasty program at MGH. He's going to talk to us about what do you need at your institution for a successful BPA program. We have Dr. Vladimir Lakter, who's a true rising star in this field and an interventional cardiologist at Temple University Hospital, who's going to talk about selecting ideal cases for a new BPA program. And we have our very own Kristen Broom, our nurse coordinator extraordinaire, who is going to talk to us about how she care coordinates for these patients and how she gets things done. So with that, I'm going to give it to Dr. Rosenfield and stop sharing my screen. Thank you, Dr. Rosenfield. It's all yours.
Thank you, Vikas. I hope I do this justice. All I can say is that I will do my best. And let's see, they can see my screen. I got to be careful what I show now, huh? I could show the Michigan, but anyway, let me just get to my slides. So I'm gonna try to whip through these, and I hope please interrupt me if you have questions. I'm not sure I exactly knew the task, but in advance. So but I think I'll cover it and talk about the issues that are relevant here. So, what do you need at your institution for a successful BPA program? I actually will tell you that I don't lead the BPA program. I lead the BPA, but I don't lead the Ctf program, and that actually is the critical component here. Is that it's not about BPA, it's about Ctf. So these are my conflicts. So let's talk about a tale of two cases. This is a 48-year-old. It's always fun to start out with a case. This is a woman on OCPs who developed dyspnea and cough after a flight 2 years ago, worsened dyspnea. She was treated for asthma with multiple steroids. Obviously, the diagnosis was missed at that time, but she represented with syncope and hypoxia and was found to have a right main PE with RV enlargement, RVSP 98. Of course, you don't ever get 98 without having had something beforehand. You have to have an underlying, pulmonary hypertension, because otherwise you'll die with that acutely. She was started on ECOS. She got slightly better. So she had acute on chronics and was treated with Eliquis, and she still had severe dyspnea. And Her pulmonary artery pressures after 3 months were 64/19 with a mean of 39 and 5 Wood units. And you can see this large gap in her on her right side, and that is confirmed by an angiogram showing a total occlusion of the basically everything except for a couple of the upper lobar arteries. So she had a successful pulmonary thromboembolectomy, surgically treated, and her hemodynamics completely normalized, which is remarkable. And you can see the specimen that was obtained. The second case is a 42-year-old guy who we treated, had a PE in 2011 in India, treated with warfarin for 4 years, switched to DOAC and admitted with dyspnea in 2017 and found to have severe pulmonary hypertension and Ctef on VQ scan. You can see multiple areas of gaps of perfusion here in the imaging study. Ventilation was totally normal. And here was his baseline angiogram showing gaps that correlated to those perfusion deficits. And you can see, in addition, there's some disruption of the artery here. It's not smooth, and there's a couple of occlusions of or subtotal occlusions of some of the branch vessels, major branches. And then this is the left lung. You can see again in the main pulmonary artery supplying the lower, the interlobar artery, there's a huge obstruction there. And on the AP view and the lateral view, you don't see as well. But although there's a lot of tortuosity of these vessels and enlargement of the main pulmonary arteries consistent with his PA systolic pressure, which was 123 with a mean of 69 and with a normal-ish wedge of 16 and a PVR of 10 Wood units, which is pretty remarkable. He was thought to be an appropriate surgical candidate for the same thing the previous patient had, but he refused it and was started on riociguat, which is what we always do to try to lower those pulmonary pressures before doing a BPA. And then the decision was made to proceed with BPA. And I think he had 7 treatments. Here's one of them here, the right upper lobe. Here's the left lower lobe on the second section, where we treated with a 7-millimeter balloon, quite large, in a main branch pulmonary artery. Here's the right lung, the second session. This is like A8, I think. Would you say, Vlad? Probably. And we treated that nicely. And again, second session in the left lung, treated another section here. I can't remember which segment this was, but another 7-millimeter balloon, multiple balloons. I think I probably dilated, conservatively over the period of 7 sessions, I probably conservatively dilated 160 vessels, or maybe more. Individual dilatations, if you include the small branches that were associated. And you can see pre and post. Pre, there was a gap here, and post, now the perfusion is better. That's just one example. Here's another view that shows this area that was underperfused now is perfused. And this is how we follow these patients. And his hemodynamics, this one case goes from 123 PA systolic pressure with a mean of 69 down to a totally normal blood pressure after BPA number 6 of 30/13 with a mean of 19. And his output concurrently increased index went from 2.9 up to 3.6 to 4. So he actually came off of oxygen, went back to work, and he had complete normalization of his functional capacity. And his RV strain pattern and rightward axis actually got better, which is pretty remarkable. So who should be considered for medical therapy versus PTE versus BPA? Well, obviously, it depends upon a lot of things: the severity of the disease, the degree of lifestyle limitation, whether they're a candidate for surgery for a variety of reasons, whether they have pH from unrelated causes, is the severity of their pH out of proportion to the obstruction? Do they have recurrent Ctef after PE? And what are the goals of therapy, and how are the clinical outcomes evaluated? And these are all questions we have to ask ourselves as we embark on these treatments. Is it return of pulmonary vascular reserve, improvement in functional status and quality of life, cessation of pH? Is it reduction in mortality? Because pH is associated with significant mortality, especially from Ctef. So how are these decisions made, and who performs the therapy? Those are as important as the questions that I just asked. So I'm going to harken back now to the PERT concept. which is to say, here's our original picture of one of our early pictures of the MGH PERT team. And by the way, speaking of CTF, Rich Chanik is in the middle here. He was part of the original PERT team. In fact, I will, I think I'm as much the driving force of PERT as anything else. I will give kudos to Rich for coming up with the name PERT. That was Rich Chanik's name. So that he, as we were sitting around a table working as a team like this, it was a team-based approach to coming up with a name too. And I would say to you that, like the PE response teams or the PERT concept, where the idea is to respond expeditiously to give the best therapeutic options, enlighten people and leverage the input of that multidisciplinary team, coordinate the care, develop the protocols, collect the data. All of that happens with the PERT should also happen with your CTF team and your CTF program and your BPA program. You cannot function as a freestanding BPA program or, frankly, in my opinion now, a PTE surgical program either. You need the multidisciplinary collaboration that is the same type that we have in PERT. And you also need to get your tattoo that says, instead of PERT, it's supposed to say CTF BPA. And your license plate has to say BPA on it, but I don't have that yet. But you need dedication and commitment. Those are critical. PTE and BPA are absolutely not for everybody, nor are they for every institution. Very much different than PERT, because this is a problem that is not nearly as common. It is very specialized. It is much more challenging. And there is time to figure out, unlike in PERT, there's time to figure out what to do and what's the best therapy for each patient. So here are the requirements or ingredients. It must be part of a comprehensive, the BPA program has to be part of a comprehensive CTF program. There needs to be an institutional commitment to the disease state. And there has to be an appropriate skill level. There has to be thorough knowledge about the disease, its etiology, natural history, progression, and so on. Those are the cognitive skills. There's clinical skills, expertise in clinical presentation, what these patients look like, which is often challenging. Expertise in evaluation management, medical therapy, critical component of this, and follow-up. Technical skills are sort of obvious, but guess what? They're not so obvious when you get into it. I've been doing balloon. I've been doing interventional stuff in peripheral and coronary, advanced stuff. I mean, the best of the farthest. I'm not saying the best of the best, but the most advanced stuff over the years for 30 plus years. And I can tell you that these challenge me. These BPAs challenge me more than any other procedure that I've ever had in different ways. And it's mostly about navigation, but it's also about knowing when to stop, knowing how large the balloon, how much the pulmonary artery will tolerate, and so on and so forth. Anyway, so you need advanced surgical and interventional expertise, facility with image interpretation and navigation in the pulmonary bed, ability to recognize and especially manage complications. And I'm talking, you need to be right there and know in advance. You need to predict what's going to happen. Perforation, hemoptysis, reperfusion injury, hypoxemia. It is not uncommon, and I'll get to the complications later, but it's not uncommon for a patient to start coughing suddenly, just a little gentle cough during the procedure. And all this, I know immediately. It's an immediate stop everything, check the back of the throat. Is there anything in the back of the throat? Is there any blood? And invariably, I would say 9 out of 10 times there is, maybe 8 out of 10. And then it's an immediate reversal of anticoagulation. You may even be able to continue a little bit of the dilatations, but it's immediate reversal and stop and make sure where you are, because you've already caused a little micro perforation. And believe me, if you miss it, that patient will cough. Even if you catch it, that patient will cough blood like the most scary stuff you've ever seen in your life. And you need to know how to stop that. So regular meetings with multidisciplinary team-based decision-making is critical. You need to evaluate every single patient on their own merits and make decisions together. And then, of course, quality assurance with M&Ms and peer reviews and collection of your data. If you don't commit to collecting data, participating in your own registry or a shared registry, which we'll talk about starting, by the way, or we've already been discussing this at length, this group, then you shouldn't be doing it. And then benchmarking against the rest of the world. So let me just, the rest of the slides are a little bit about CTF. And since I don't know how much this audience knows about CTF, but since it's a pretty familiar audience, I'm just going to quickly go into it and try to cover some bases, but I'll try to whip through because I have too many slides. So obviously, this is from Eric Klock's recent article, or actually not so recent, but 5-10 years ago, that shows, where does CTEP, where is it? It's one of those post-PE syndromes as PE transitions from acute to chronic, but very small number of patients actually get CTEP. More of them have this, CTED or post-PE syndrome. They're not quite right, but very few actually get CTEP. And what is it? Why do they get it? It's incomplete dissolution of the clot, fibrosis and scarring within the pulmonary vasculature, and loss of distal perfusion in the bed because of and resulting progressive pulmonary hypertension greater than 25 mean PA. And that's as a result of the scarring and occlusion or subtotal occlusion of these vascular beds. Multiple vessels. It usually involves a smattering of vessels. You're lucky if it involves only a few major vessels. Most of the time, it's not the case. The natural history is terrible. It's a devastating disease with terrible mortality and a very poor quality of life. These patients are desperate for therapy, desperate. And you can see here if they have PA systolic pressure of greater than 50 mean, they're gone within 6 years, 5 or 6 years. Amazing. What other things have that kind of mortality? So it's also yet, in spite of that horrible prognosis, is one of the most curable forms of pulmonary hypertension. And if you detect it, if you think of it, then if you need to think of it first, just like PE, it's a diagnosis that's sometimes hard to make. Obviously acute PE patients with persistent chest pain or really shortness of breath and so on after 3 or 4 months, then you start thinking of it. All patients, frankly, all patients with PH, you should at least think, could this be CTEP? And, should we do a VQ scan and just rule it out? And I would advocate for that because I think I've seen several patients in whom other diagnoses, they thought it was just primary pulmonary hypertension or some other secondary pulmonary hypertension from heart failure or whatever. And it turned out that they had CTEP. So if you have a patient that has unexplained dyspnea, even if they've not had a thromboembolic event, you should think of it. You should check an echo, check the size of their LV and the function and the thickness of the wall, and a VQ scan, which is really the best way to really make this diagnosis. A CT angiogram and a pulmonary angiogram, these also are incredibly important. They have to be done as part of the workup. The diagnosis of PH should be considered, or CTEP should be considered in all patients with unexplained dyspnea, and CTEP in all patients with PH. Actually, that's PH should be considered in all patients with unexplained dyspnea, and CTEP in all patients with PH. And then, of course, measuring the pulmonary hemodynamics and so on is important to assess their surgical candidacy and also that candidacy for BPA. So as I already said to you, a VQ scan is critically important. You can see here's a case with lots of gaps in the perfusion. And I don't read these things very well, but I can tell you when there's CTEP and when there's not. And you need to be able to understand that too. So what about the invasive evaluation? Right heart cath provides that incredibly important and objective evidence about the pulmonary pressures and so on, and the cardiac index. It also gives you a risk adjuster for mortality if they go to the operating room, because if they have a PVR that's greater than 1100, their mortality is exorbitantly high, 5 to 10%. So that actually weighs into the decision-making about what to do. And at the same time as the right heart cath, you can do a PA-gram, which is the gold standard. It confirms the diagnosis of CTEP and provides an anatomical map for the surgery or the BPA. And you got to do the injections right. These are good injections right here. I'm going to tell you, I see so many crapo injections. You got to learn as part of your BPA program how to do the right kind of injections. And we can talk about that. We're going to have a manual coming out about how to do this stuff. Those of us who are doing this on this call are talking about that. I can tell you my routine is to do a subtracted angiogram, 23 cc's per second of sort of 90% dilute, 10% diluted contrast for a total of 35 cc's for each injection. So that's like, they get 120 cc's or so of contrast during the entire AP and lateral. I do AP and lateral on each side, as you see here. And you can see the telltale marks of CTEP narrowed here and occluded here, hypoperfused here, narrowed web here on the left side, and so on. It's critically important if you're going to be part of a program, a Ctf program and a Bpa program. If you're going to be doing Bpas, you better know about the drugs because they're critically important. If you're treating somebody with a Bpa and you haven't treated them with Rio to try to bring their pressures down, you're not working with a pulmonologist in the right group. You don't have a good team together, then you're missing something because almost all of my patients are either on Rio or on macitentan or some other thing to bring their pressures down to make them safer to do their procedure. Now, just briefly about PTE, because this is not about PTE, but it's critically important. You need to know about PTE. When is it done? When is it not done? Who qualifies? It's actually, the curative treatment, and it's a single treatment. And while it's a very high risk and challenging procedure, if it's done properly by somebody who's well-trained and qualified and knows what the heck they're doing and highly experienced, you can get superb results. We have two surgeons who are phenomenal at this. I know that at Temple and at Michigan, they have surgeons, and I don't know where else, but many other places. But you got to have, obviously San Diego, which is, the granddad has done a lot of these. But you would have to say that PTE is currently the treatment of choice. This may be evolving, but right now it is the treatment of choice. And the outcomes are phenomenal. Here's the UCSD outcomes. When you get into the hands of Mandani, you're going to get a good result, by and large. He's done so many of them. And by the way, survival is also much improved compared to those matched controls who are not operated upon in the Ctef group. So what's the role of PTE for Ctef? You need to know the outcomes and the data. If you're going to do Bpa, if you're going to be involved in a program at all, you need to know the outcomes and the data. And you need to know that surgery with a complete PTE is probably the best therapy you're going to get. And though it's technically challenging, there are excellent outcomes if you have an excellent center and so on. But 40% of patients or so are not surgical candidates, even in the best of centers. Some are not operable, and 20% actually will have residual pulmonary hypertension post-PTE and might be candidates for an adjunct Bpa, which, by the way, in that particular group of patients is really challenging, and you really need to know what you're doing in those patients. We'll talk for a second about Bpa, or a bunch about Bpa. Vikas, can you just tell me, I don't have a watch in front of me. Can you tell me what the time is? Because I don't want to go too far over.
The time is 6:23. I think you'll be good if you could wrap this up in the next 2 or 3 minutes.
I'll just, we're going to talk about Bpa. I'll just say that, it was initially, and this is the telling thing, high complication rate initially in the first publication, 2001, which stopped everything. And nothing happened for another few years until they reemerged by the Japanese undertaking this because they don't have PTE readily available. So a bunch of, Matsubara and others took this on and started doing them and actually had remarkably good results. And, I'll just, there was concern initially that these might be kind of not reproducible, but it turned out that in the European literature, these good results of improvement in PA pressures and PVR and increase in 6-minute walk tests and so on, all of that was comparable. Complications, I talked about complications. Hemoptysis and reperfusion injury are common. You need to be very aware of them and how to manage them. And this is something you do with your pulmonologist, your critical care people as a team. Coughing is often the first sign of a complication. Reperfusion injury may not become immediately apparent, and you need to watch these patients closely over time and know how to interpret the chest X-rays on the next day, on the next day's X-ray. There's a large body of evidence that this is now an effective treatment, and therefore it's been incorporated into formal guidelines. You can see in the algorithm of how you assess operability and so on, if they can be considered a Bpa candidate in an expert center. At our center, it's incorporated into the overarching Ctf program. It's team-based with buy-in from all. And we've, in our first year, we did 11 patients in 39 sessions. Now we're up over 200 procedures. We've incorporated our own multidisciplinary planning session and use our own algorithm for how to evaluate these patients. And I'm happy to share that with anybody with deference to Josana Rodriguez Lopez and Allison Witkin, and prior to that, Sasha Wong, and prior to that, Rich Chanik, who helped develop this. Here's the checklist. You got to have capable people that are credentialed, trained, and proctored, monitoring equipment, and so on. I'm the only one that's been doing it at my place, but my fellows have been learning, and Vlad is one of them. He's now a superstar, but I'm now training another person in my place because it's a lot of work for one person, and it's a lot of radiation. You need to have your reports in good form. This is an example of a report that I did, and believe me, I go into every little subdivision. These take me a long time to do. I don't leave them to the fellows. I do them myself. They're a lot of work. I won't go into great detail. We've had good results showing decrease in pulmonary pressures and so on and so forth. A word about complications. Death happens. I know of it. I've seen it. I've not had one, but I can tell you I know a couple of my friends have. Hemoptysis is, you will see it. You need to know how to deal with it. And pulmonary hemorrhage. I've had to coil a couple of people. I've had to balloon a couple of people, prolonged balloon inflations, and so on and so forth. You need to know how to deal with these things. This is pulmonary hemorrhage. It's not a good thing. You need to know what it looks like. And I won't go into to anything more in detail on that, but this is for the more, those who are really going to do this and do it well, and proctor well and train well. Yeah, then we'll teach you all. But not every place should have one of these programs. I really don't think so. It's just one of those things that's pretty specialized. So I'll stop at that point and happy to answer any questions afterwards. I'm sorry to go over a little bit, but I do think this is an exciting field and one that we're now incorporating to the PERT consortium as a part of the pulmonary embolism spectrum, if you will. If you're not a member of PERT and your institution is not a member of PERT or doesn't have a PERT, create one and join the team. We can help you get started. Thank you very much.
Thank you, Dr. Rosenfield. That was awesome. I'm going to now ask Kristen to share her screen and talk about how she coordinates the care of these patients, at Michigan.
Thank you, Dr. Agarwal. All right. Hello, everyone. Thank you for having me. My name is Kristen Broom. I'm a registered nurse and clinical care coordinator for interventional cardiology team at Michigan Medicine. I would like to talk to you today about my role in the Balloon Pulmonary Angioplasty clinic and the challenges we face as we care for the CTF patient population. I have no financial relationships or conflicts of interest to disclose. So what I'm hoping you will learn from this discussion is to define the clinical care coordinator role, identify the challenges we face from a clinical standpoint and what obstacles patients may encounter as they progress through their CTF treatment. And I'd also like to talk to you about my role in a growing Bpa program. So what is a clinical care coordinator and what do we do? We are registered nurses that wear many hats and typically serve as a liaison between the clinical team and our patients. These patients have complex cardiovascular needs and require ongoing support through their care. We utilize our nursing skills to assess patients. We provide education. We also provide ongoing psychosocial support because these patients are already going through a lot. So we like to be there for them to make sure that all their needs are met. And also we have patients that come from all over the state and the region. So we work closely with their local providers to ensure a smooth transfer of care. And a lot of times we are the point of contact for patients and help them navigate these really muddy waters, especially at large institutions. Patients often feel lost after a diagnosis of CTF and they need the guidance. So it helps them to feel at ease to have a familiar person or a voice to talk to when they reach out. So there are some unique challenges in care of patients with CTF. Typically, these patients are diagnosed late in their disease process, and they have already been put through the ringer of endless tests and multiple clinic visits. And by the time they make it to our team, they're exhausted. So we just have to be cognizant of their lived experiences up until this point. So these patients are not your run-of-the-mill retiree with a strong social support, adult children and endless community resources. They usually have young families. They're working full-time, their spouses are working full-time, and they're also likely experiencing some PTSD related to this very uncommon diagnosis. Although CTF patients finally have some answers in a diagnosis that, helps give them some answers, they have some light at the end of the tunnel. The new diagnosis also comes with its challenges. They may experience bleeding or clotting issues as related to their hypercoagulable state and their chronic anticoagulation. So some have already had frequent DVTs, strokes, or even heart attacks. Some patients plan to grow their family still, and they face the fear of the unknown as related to future pregnancies. So this infographic was pulled from the Pulmonary Hypertension Association site. Currently, there are only 67 accredited pulmonary hypertension programs in the US, with less than 15 of them offering CTF treatment options. So access to these therapies are limited, and it creates a logistic challenge for getting these patients the care they need. Because we are one of the few programs in the region and the only CTF treatment program in the state, we encounter several psychosocial issues, transportation concerns, lack of familial support for our patients, financial hardships, and also insurance coverage issues. So it's really important for us as a clinical care coordinator to identify these challenges with the patient. So this basically shows that we have folks that travel long distances to see us. And we pulled this tweet from the Australian government, and it explains available support options for those patients in Australia that have limited access to care based on their geographical location. So it's a great resource, but we don't live in Australia. So, however, we do have great resources available to us here at Michigan Medicine. And our team is armed with many supportive programs, including social work and our guest assistance program. We have lodging options, support to help patients that don't have any insurance. And we also have financial assistance, and our billing and pre-certification department can help patients estimate their out-of-pocket costs when they come to see us. So as a clinical care coordinator, we know how to maximize these resources. And our goal is to provide comprehensive medical care, much like a concierge service for our patients' medical needs. And as a nurse, we like to take a holistic approach to caring for our patients. We would like our patients' experience here to be a very positive one, despite all the obstacles that they may be facing and have already faced. So this is an example of how patients are moved through our CTF program. First, they come to us through a referral of through our pulmonary hypertension clinic or an inpatient transfer, and they are either diagnosed with CTF at that point or their diagnosis is confirmed. So then the plan is for them to undergo invasive diagnostic testing with a pulmonary angiogram, a diagnostic right and left heart cath with sometimes coronary angiography, and an invasive cardiopulmonary exercise test. All of these invasive procedures are done through the cardiac procedures unit cath lab. And these are coordinated and scheduled by myself or my colleagues. And we take the patients from beginning to end of these procedures. So after that, once the invasive testing is complete, their case will be presented at our multidisciplinary conference. From there, the decision is made whether their disease is operable or non-operable. If they have surgical accessible disease, they will be referred to our cardiac surgery department. And if they have non-operable disease, the decision will be made whether they should continue medical management, and then at which point they will return to the pulmonary hypertension clinic, or if they are a Bpa candidate, then their care will be moved to the Bpa clinic. So patients, when they're referred to the Bpa clinic, we typically like to see them in person. And we discuss the pathophysiology of the CTF disease, and we also go in depth about Bpa. We discuss the risk versus benefit as evidenced in our current research. So when the patient makes the decision that they would like to proceed with BPA, we decide how many cases they will need. And there's a lot of factors that determine that. So typically it's between 4 and 8 sessions. And we also have to take into consideration whether these patients have any schedule restrictions in the near future. So if they have a family wedding, or their daughter is graduating from college, or they have a vacation to Hawaii planned, we're not going to bogart the next 3 months of their life and keep them from doing the things that they love. So we like to work around their schedule and get them the treatment that they need at the same time. We also schedule patients for a CT perfusion angiogram for procedure planning purposes. And then we also make sure that they have all of their baseline testing completed, including an echocardiogram, the 6-minute walk, a VQ perfusion scan, the invasive pulmonary angiogram, lab testing, and PFTs. So this is an example of what our Bpa calendar that we customize for our patients will look like. Typically we do 4 to 8 sessions, but this example shows 6 sessions for a patient. And we lay it out in a pattern of 1 session per week, 2 weeks back to back, with 1 week off, and then following that with a pulmonary hypertension clinic visit and a 6-minute walk to assess their improvement in between each session. So before the procedure, the clinical care coordinators in the cath lab, we assess the patient's history and determine the appropriateness of a sedation, or if a higher level of anesthesia is needed. For example, if the patient is unable to lay flat due to a longstanding history of back pain. We also complete their pre-procedure testing and instructions, and we evaluate for allergies, COVID. We, of course, do COVID testing and routine labs. And they get their instructions that include when to stop their medications for the procedure, when to stop eating, that sort of thing. So the most important thing is that we discuss their anticoagulation management with the anticoagulation pharmacy team. We also look at possible bridging with the anticoagulation pharmacy team. And patients that are on warfarin will typically be transitioned to a NOAC, such as Eliquis, to ensure they remain therapeutic throughout the procedural period. So we also take steps to ensure that patients prevent contrast-induced nephropathy, and many factors affect the amount of hydration that we provide, such as if they have valvular dysfunction, baseline renal function, or if their ejection fraction is low. We follow the dedicated protocols for these high-risk scenarios. So on the day of the procedure, the patients arrive to our cardiac procedures unit and follow the standard process. So they get consent from our advanced practice team. They get their prehydration per the protocol, and then they go to the procedure. So after the procedure, they will recover overnight in our outpatient procedure unit, which is in our cardiac procedures unit. And for patients that have had any complications during the procedure, or if they're a higher risk case, they will recover overnight in the ICU. We also have the ability to complete these cases in the hybrid OR when highly specialized equipment is needed. And we also have available to us interpreter services for the patients that English is not their first spoken language. So after the procedure, we make sure that they are scheduled to see the pulmonary hypertension team, as well as their 6-minute walk. And we also want to make sure that they're on track for the successive BPA cases following. And, of course, with any invasive procedure, there may be complications. And, as a clinical care coordinator, we need to be able to triage those possible complications, such as access site issues or hematomas, acute kidney injuries, any symptoms that could be as vague as chest pain, or hemoptysis. And we just want to make sure that patients know who to contact when and if they experience these issues. And we also want to make sure that the patients are resuming their normal medications, including their anticoagulation. So after the BPA sessions are complete, they've completed their 4 to 8 sessions, the patient will resume routine care with their pulmonary hypertension provider. We also recommend follow-up testing 6 months after their last BPA session to assess their status. And that will include an invasive right heart cath, echocardiogram, labs, and a 6-minute walk. And then this grid summarizes the patient flow through our testing clinic and the procedure. It shows what is done at each stage through the Ctef clinic in a nice little package. And then, although this is a lot of work to manage this very special patient population, it is also gratifying to see them do so well after their treatment. They're once again able to do the things that they haven't been able to do for years. The young mother is able to run after her kids, and the guy that was a firefighter up until he had his first PE, he's now able to run up a flight of stairs without having to sit down and rest. So as the medical community continues to standardize treatment for Ctef, one of my goals is to continue to provide supportive care to this program and to this vulnerable patient population. Ctef patients are often diagnosed late due to their vague presentation, and they have already been through so much as they are diagnosed. We think it's important to understand their experiences as we work with them and individualize their care. I look forward to being a resource for the patients and the nursing community as we navigate the path of Ctef treatment. So thank you very much.
Thank you, Kristen. That was wonderful. Thank you for sharing all the information with everybody. I'm going to now give it to Vlad, who's going to talk to us about how you pick the ideal cases for a new program. That's all.
All right. Thank you guys very much for inviting me. This great session, and I'm going to share my screen now. All right. All right. You can see my full screen, I hope. Okay. So,
yep.
My name is Vlad Lochter. I'm one of the interventional cardiologists, vascular medicine physicians at Temple. And today I'm going to talk to you guys about selecting an ideal case when starting off a new BPA program. So I don't have any relevant disclosures. And I think it is, it's important to set up for success when picking cases that are going to be going for balloon pulmonary angioplasty. That first and foremost, as Dr. Rosenfield highlighted, involves making sure that the patients that are ultimately decided to undergo BPA are evaluated thoroughly by the comprehensive Ctef team. And I think it's hard to understate that. You can't pick these patients on your own as the interventional cardiologist from somebody who's referred to you directly. I think this is really a product. BPA is a product of the comprehensive Ctef program that includes medical management, surgical management, and BPA as the options for treatment for these patients. When patients are ultimately selected to undergo BPA, there are several things that I think are important to consider in order to minimize the complications. And I think we certainly can help these patients with BPA, but we can also hurt them. So I think minimizing the risk for these patients is extremely important. And here are some of the things that I think are important to consider to minimize the risk. So a lot of times we'll do multiple stage sessions instead of trying to fix everything all at once. We'll usually treat one lung at a time, when occasionally we'll go over to the other lung if we're not treating a lot of segments on one, but most of the time it's right or left lung. We'll use undersized balloons first, and we'll go over what the distal pressure monitoring is. That allows for limiting fluoroscopy and the total contrast administration at the time of BPA. There are also considerations for selecting the correct target lesions at the time of BPA. So I think one of the articles published in JACC and Regis suggested treating the right lung first before the left. I think that's if there's more disease on the left side than on the right side, I think that's you would go for the left lung first. But I think what's more important is treating the lower lobes before the middle lobe lingula or the upper lobe, because you will have the most restoration of VQ matching by treating the lower lobes before the middle or the upper lobes. Also considering the lesion morphology that you're approaching. So treating the webs, narrowings, and the bands are a lot safer, as you'll see, than treating subtotal occlusions, CTOs, or patients who have tortuous vessels. And then also consideration of pressure monitoring distal to the lesion, which I'll show you. And then one thing that if you have an opportunity to do the cases with your senior partner, I think that's really important. I've had the luck to work with Dr. Rosenfield back when I was a fellow, and I learned the BPA from him and my now senior partner, Dr. Bashir. And so we tried to do, Dr. Bashir and I tried to do the cases together as much as we can to, to help each other out in case a complication happens, and also from my standpoint, also to learn. So I think that's a very important part when starting off as a BPA operator. So what are some of the higher risk features at the time of BPA to watch out for when selecting patients? So patients who have very high baseline PVRs will have a higher risk of complications if there is a wire perforation, because the patients will be bleeding at a much higher pressure. There are some anatomic considerations that put patients at high risk, such as the lesion type. As I'll show you, the presence of vessel tortuosity. If the lesions are predominantly distal versus more segmental in nature, and if there's interlobar involvement. And one specific patient subgroup to point out are the patients that already underwent pulmonary thromborectomy are at higher risk of complications compared to patients that have not had ET in the past. So the RAISE trial, just to highlight a couple of findings, was an interesting trial that randomized patients to BPA versus riociguat for patients with inoperable Ctef. And the extension of this trial found, for the purposes of this talk, that patients that were pre-treated with riociguat for 6 months prior to BPA were much less likely to have a complication at the time of BPA compared to patients that were treated with BPA first. And that was true for overall risk of complications as well as the risk for lesions. So if patients have a very high baseline PVR, perhaps delaying treatment with BPA and first pre-treating patients to lower that PVR will reduce the procedural risk. The next step is considering the lesion types. And here, so these are some of the lesions that are favorable for BPA, and the risk of complications is the lowest. Those lesions include the ring-like stenosis here, the webs. And you can see that the vessel on the other side is patent. So when your wire will go across, you will be able to inflate the balloon with less likelihood of injuring that vessel. Here's what a web looks like on OCT. And you can see that the wire has many opportunities to go through any one of these channels, and then the balloon will modify that channel to become a lot larger. The lesions that are more complex and may not be the first lesions to treat, if the webs and bands are present, or the subtotal occlusions. You could see here that there's a pouch defect with two very thin lines of contrast that emanate from it, which are and the wire has to be able to cross into one of those channels to dilate the vessel. Even more higher risk than that is the total occlusion, where in this case it's a blunt total occlusion, where you do not see the vessel on the other side. And you can imagine that although you may be able to find the channel, there's also a higher risk of perforation compared to a vessel that's patent. The highest risk vessel anatomy are the tortuous vessels, like shown here. And these are the vessels that have the highest risk of complications. So here's sort of the summary that if the patient has a ring-like stenosis in the web, those are really the lesions that you're looking to treat first. The complication rate is low and the success rate is very high. And as you progress to subtotal occlusions or to total occlusions, the complication rate starts to go up. The success rate is still fairly high. And in this paper, the complication rate of treating these tortuous vessels the complication rate was up to 40%. So these are certainly not the lesions you would want to select first. Here's an example of a patient with a chronic total occlusion of the A10 segment. And you'll see here that not only is the vessel occluded, but the vessel immediately proximal to that occlusion has complex anatomy. And in in a setting like this, wiring of this vessel may lead to higher complication rates. You just have to be aware of that. Here's another example of another subsegmental branch that has a CTO, and we, while wiring this vessel, the vessel unfortunately exited. The wire exited the vessel, and you'll see here that there was a blush of conscious that was escaping through the vessel, which was controlled, thankfully, fairly well with balloon angioplasty. But this is something you have to anticipate when you're seeing these lesions. These are not the first lesions you may want to select. Here's an example of a vessel that's tortuous. And again, wiring a vessel that's tortuous may in some cases lead to wire exit out of the vessel. If you have the patient take a deep breath in, it will augment the vessel and stretch it out in a more straighter path for wiring. So the patient population that has previously undergone pulmonary thromborectomy is a particular population to be aware of, where the complication rate may be higher than the native anatomy. And you can see here, this is a patient that these are two patients that underwent pulmonary thromborectomy. And although clot material is removed, sometimes the endothelium is also denuded. So the vessels that are left over, some of them will not have the endothelial protection, and the wire may exit easier. Here's an example of a patient that had a pulmonary angiogram prior to pulmonary thromborectomy. And this is the pulmonary angiogram after several years afterwards, because the patient had residual pulmonary hypertension. And you can see that the morphology of the vessels, even the angulation of the vessels after pulmonary thromborectomy changes, and there's sagging of the vessels. So the vessel morphology really is different. Here's one case that we had of a patient post-pulmonary thromborectomy who had a stenosis in one of the posterior lower lobe branches. And in wiring the vessel and then performing balloon angioplasty, the patient developed a fairly significant hemoptysis right there in the case. This ultimately required us to get contralateral access, inflate a large balloon to tamponade out the vessel. The patient was intubated, and we actually had to, in this particular case, place an Amplatz vascular plug to embolize the vessel completely because of persistent hemoptysis. The patient did well, and here's the final result. But so you can see how the morphology of these vessels are just not straight, and the endothelium is denuded. The other patient population to be aware of are the patients with hemoglobinopathies, also not the first case that you may want to select. Here's one example of a patient with hemoglobinopathy with sickle cell. And you can see that the issue here is there's diffuse perfusion defect essentially in every single segment and in every subsegment, and the perfusion defects are very distal. So to be able to successfully revascularize this patient and lower and improve their hemodynamics may be challenging, and it's going to require multiple sessions of BPA. So again, not the first case to select. Here's a more selective angiogram of this patient with hemoglobinopathy. You can see that although the vessel is patent proximally and in the mid segment, but the very distal branches do not have any significant perfusion. So you really have to wire all the way out to the periphery and perform angioplasty far out, increasing the risk of complications. And again, some of the other examples of this patient's distal defects. I'm just going to kind of skip through these slides to on here. So who should we pick for BPA? So here's an example of a patient that I think fills some of the criteria of an ideal patient. I'm just going to briefly review the background history. So it's a 47-year-old patient who had a history of splenectomy. Splenectomy is a known risk factor for pulmonary embolism and for recurrent small vessel pulmonary embolization. Sometimes these patients present with CTF as their initial diagnosis, never having the diagnosis of acute pulmonary embolization. You can see that just in these two perfusion images, the patient has bilateral perfusion defects predominantly on the right side. And this particular patient, this representative clip of their transthoracic echocardiogram, had significant RV dilation and interventricular septal flattening. This patient underwent pulmonary angiography. And you'll see here that although you have evidence of perfusion defects, it's not that patchy, diffuse diffuse perfusion defect that we saw in the patient with hemoglobinopathy. And here's the left side, which was where the perfusion was fairly preserved compared to the right. So if you look at the VQ scan side by side with the PA-gram, you could see that the perfusion defects were matched in the upper and middle lobe and in the lower lobe. And if you kind of zoom in here, you'll see that, I know the resolution is not the best, but you'll see, you have a sense that the vessels are present leading up to that perfusion defect. And the perfusion defect, the vessel is patent more proximally. So there is an opportunity to perform BPA. It's not a total occlusion. It's not a subtotal occlusion. So this is going to be most likely a web-like stenosis, which we know will have a higher success rate and low risk of complication. So here's an example of selective angiography within this patient. You can see that the upper lobe branches, the apical branches are fairly preserved. There is a perfusion defect in the anterior segment. And the perfusion of the posterior subsegment looks fairly preserved. So the vessels are present. When we get down selective into the right lower lobe, I'm sorry, in this case, in the right middle lobe, you could see multiple areas of subsegmental webbing and stenosis. So, but the vessel is patent, thereby increasing the chance that we'll be able to be successful in opening it. This is selective injection of another right middle lobe branch here. And so you can see basically the point here is that this patient had all of the vessels were patent and were predominantly affected by webs and diffuse stenosis rather than occlusions or distal disease. So in this particular case, we selected the right lower lobe and the right middle lobe as the first treatment targets for BPA. And after balloon angioplasty with an undersized balloon, you can see that the vessel fills much further out. Granted, the vessel does not look normal when we're done, but you'll see that it certainly looks, the flow is further out and is much improved. What we do frequently and routinely is that we use a pressure wire to guide our BPA procedures. We will usually use an FFR wire, and you'll see here that when you cross a stenosis, that the pressure on the other side of the stenosis essentially looks like a wedge pressure, whereas proximal to the stenosis, the pressure looks like a normal PA pressure. And when you perform BPA, you're able to increase the distal pressure to whatever your target is. And we intentionally undersize the balloons at the first setting and keep the restoration of flow not less than 50% in order to try to reduce the risk of pulmonary edema at the end of the procedure as a result of reperfusion. And we've had good success at keeping our patients fairly low risk from reperfusion pulmonary edema. So here's the right middle lobe, the lateral segment. Again, balloon angioplasty with an undersized balloon, and you'll see again that the flow and the perfusion improves, but the vessel, you could still see residual stenosis. This is A8. In this particular case, the vessel appeared to be diffusely diseased in the mid to distal segment, but the wire passed fairly easily, and afterwards there was very nice restoration of flow and as well as pulmonary venous return. So I'm not going to show you all the angioplasties in the interest of time, but the patient subsequently underwent also BPA of the upper lobe, and you can see here that from compared to the initial pulmonary angiogram, there was significant improvement in perfusion in the right upper, middle, and lower lobes. This particular patient, the VQ scan and follow-up showed significant improvement of the right lung. This patient did not undergo BPA of the left lung because the perfusion there was much better. The patient's 6-minute walk distance improved, PVR decreased, and the transthoracic echocardiogram essentially normalized. And so here's this is our Ctf team that evaluates every single patient. And again, just to reiterate that every patient that's ultimately undergoes BPA is evaluated comprehensively. And by the time we meet the patient, there's already a plan in place. We have a sense of approximately how many BPA sessions the patient will need to undergo and what the follow-up will be. And that's it. Thank you very much, guys.
Thank you, Vladimir. That was excellent. Thank you to Dr. Rosenfield and Kristen as well. I'm going to just share my screen and share some final take-home points with everybody. So I have a brief equipment list in the next 2 slides. Most of these things are present in most cath labs, but just for folks who are taking notes. That's the basic Bpa equipment list that we use. Apart from this, we also have essentially a complication box that we share with the coronary CTO team, and that has coils and amplified vascular plugs and all kinds of other things. We have I have a brief algorithm on how we manage acute hemoptysis during BPA. This was also published by Dr. Mahmood. And if folks want to learn more and see more, I know we are limited by time today. We have several videos. They are on the Society of Cardiac Angiography and Interventions website. These are the links on how to perform a diagnostics pulmonary angiogram, how to interpret a pulmonary angiogram, how to perform a balloon pulmonary angioplasty. And we are posting more and more on the website. So please feel free to use that as a resource. It's free. It's available to everybody. If you type in my name on the search box on the Sky website, you'll be able to see every single one of these. And then last but not the least, we also have a YouTube channel that this session will be recorded and posted on in the next day or so. So you have access to the slides. You can always send us a message through email, Twitter, and so we are here to help and we are here to learn from each other. Thank you for your time this evening. And just a quick word about the next session that would be next month, and that would talk about how we set up a dedicated outpatient pulmonary embolism clinic. So with this, I know we are just about at the hour. I would like to thank my panelists, and just so one final comment from everybody, so one at a time. Sanjam, do you want to say something?
No, I'm excited to be a part of this program. The presentations were excellent, and I'm looking forward to the next session. So good night, everybody.
Sarah?
You're muted, Sarah.
I'd like to echo that. Thank you to our speakers. Those were excellent talks. And I just want to reiterate what Kenny said, is that I think BPA is a really important growing part of managing our patients, but that it does need to be done in the context of a comprehensive CTF center.
Scott?
Thank you, Vikas. Thanks so much for including me. I just am so impressed by the questions that have already started coming from the audience. Look forward to learning more from everybody. Thank you.
Brandon?
It's hard to follow those comments from the other panelists, but speaking from someone that works in a community setting, having access to a CTF center in a program where your patients can get BPA, establishing relationships is paramount for treatment of those with CTED and CTEF. So establish and reach out to those centers in your community and surrounding areas. And if you're in Michigan, reach out to Michigan's program.
Victor?
Hi, Vikas. Thank you, everybody, for the presentation. I mean, everything was top notch. I want to echo just a few things. I think that the concept that this is a multidisciplinary approach. I don't think that one person can manage these very complicated patients. I treat patients with pulmonary hypertension, with different kinds of pulmonary hypertension, and I always tell Vikas this is a subset of PH patients that is the most challenging, the most complicated, the ones that requires a lot more thinking and consideration. And when you're thinking about starting a BPA program or a PH program, I think that you should always think about selecting the most simple patient, the one that has all the most favorable approaches. And if you have any questions, thoughts, I mean, you can always reach to us and we'll be happy to help you out.
Okay, thank you, everybody. Thanks to Cray for organizing, and Erica and Sharon for the marketing team, and Dr. Rosenfield, Vlad, and Kristen for excellent presentation. Until next month, have a good night, everybody. Take care. Bye-bye.
Bye, everybody.
Bye-bye.
Thank you. Bye.